Hello, and welcome back to another episode of Straight Up with Steph. Today, we are talking all about local anesthesia. I decided to bring on my friend and fellow dental hygienist, entrepreneur, anesthesia expert extraordinaire, Tina Clarke. She's going to answer some questions today like, how do you handle difficult patients? How do you handle those humongous tongues that we see? What if the patient doesn't open wide enough? How can you stay ergonomic while you're injecting? Do topical anesthetics work? Is it okay to use Articaine on the lower jaw? And also her opinions on the Synapse pain device. If you haven't heard of it, we'll talk about it. And also buffering anesthesia. But we start off the conversation today talking about a situation that Tina found herself in online. She experienced the dark side of social media. So here's the deal. In Oregon, where Tina is, dental assistants are now able to administer local anesthesia. Tina, being the educator she is, and she specializes in local anesthetic, she was one of the instructors to train the first group of dental assistants in local anesthesia. She posted about it. She got all kinds of hate, comments, bullying online because of her choice to train these dental assistants. And whatever your opinion is on this, and honestly, I don't even know what mine is yet. I'm just more curious to see how things play out. The reality is dentistry is changing. We do have dental assistants being able to do local anesthesia. Some of them are even able to do some hygiene duties depending on what state they're in. It's happening. And so we need to make sure that these dental assistants are getting the highest level of education possible, right? And who better than Tina for that? She tells us how she navigated through that, and there's some real wisdom behind her actions and what she talks about today. So I hope you enjoy today's conversation with Tina. Hey, it's Steph, and welcome to the Straight Up with Steph podcast, where we have real discussions around health and life and just trying to be better at both. Hey, Tina. Oh my gosh, thank you so much for joining. I am really curious to hear everything that you've been through because you've experienced kind of the dark side of social media lately. And so I want to hear about that.
Yeah, thanks, Steph. And I always enjoy our conversations together. Recently, I would almost kind of say like if you've been under a social media rock, I'm thankful or glad or whatever. You know, there's a lot of power in social media. There is a lot of happiness and education that can come from that. But on the other side, there is an opportunity for individuals to disagree and also be very mean and nasty with that. So for those of you that don't know, I'm an anesthesia passionate individual. I'm an educator, and the state of Oregon back in November authorized the scope of practice change for dental assistants. And then this April, I had the opportunity to certify the very first dental assistants in the state to administer local anesthesia. And then also come to find out they were also the first dental assistants in the nation to administer block anesthesia. We're not the first dental assistants in the state or in the nation, right? Minnesota has that from a couple years ago. Anyhow, I had posted that I was like, wow, history making moment, certifying these dental assistants who dedicated a lot of time and energy and effort into the education. And the majority of the original response was a lot of anger and frustration, especially personally directed towards me and not necessarily the issue. And so it was a big challenge. There was a lot of mean and hurtful things said.
Well, and it's like, I mean, we're all not going to agree on stuff, right? And that's fine. I mean, you and I don't, like, we've had things that we don't agree on and we still love each other. It's fine. But it's where it gets personal and people are directing or attacking you as a person publicly. That's when it gets a little weird.
Yeah, you know, it was really sad. I knew that I was going to receive some professional heat, so to speak. And I had forgotten what it felt like to wrestle with that change process because I've been in that world of dental assistants performing local anesthesia off and on for 10 years. Like in Oregon, it's been off and on for 10 years, this conversation coming up. And so I had forgotten my own personal struggles with how does that fit? Like, how does that affect me as a hygienist? How does that impact patient care? All of those things, I had forgotten that personal struggle. And even when Minnesota authorized dental assistants, and I had already been involved in the conversation quite a bit here in Oregon, I was even like, oh, like, wait a second. And so having to take that moment back. And so I knew like there were going to be individuals that were going to wrestle with that. Hindsight, like I do not regret posting anything. Hindsight, maybe providing some education prior to like what that looks like might have been helpful for the dental community. But yes, the personal attacks were pretty intense. I had people messaging me in the DMs and even just on posts saying, you know, I'm a disgrace to the dental profession. I'm a traitor. I even had somebody DM me say, if I ever see you at a conference, I'm going to come up and smack you across the face because this is ridiculous. And I was like, wow, like, it kind of was like, what? Wow. I was like, I didn't realize that there was so much anger in people's hearts in regards to that. And it's so easy to do when there's no face
Yep.
behind the keyboard, right? You can just type whatever you want. And what's really funny is oftentimes I would go to like who is this person? And it was just like a picture of a flower or a dog or something like that, and no other information about who they are. And so it was like, okay.
Yeah, people can get real brave behind a screen. For those who don't know, I had done a quick post in support of Tina, and I got a comment on there, and I commented back just saying like, this isn't an assistant that someone's just grabbing off the street and training them to give shots. You know, these are FDAs, they have training. So I was trying to have a rational conversation with her, and she deleted my comment and then blocked me. So I'm just like, and I've had experience with those types of people too. And like, you can't reason with them, but I understand the climate that we're in right now in dentistry. And there is a lot of anger and resentment. And so I imagine it might be the cumulative frustration that people are feeling right now. And they just directed it at you, which sucks.
Yeah, absolutely. I understood that very early on, especially when the announcement with Arizona coming up with a new professional designation. Like I just like it literally is a new professional designation.
Right. Yeah.
When you look at it, I was like, wow, having that and this happening within a couple of weeks of each other, this is going to be just tinder to the fire.
Yeah.
And so I knew that, and I knew that a lot of the frustrations that were personally directed at me were just in general frustration. So I allowed myself to not let their anger be at me and just be about the situation. And I just happened to be a voice and a name that they could target. So that for me was a big personal growth moment.
Yeah.
To try really hard to not take it personally and just go, there's frustration and anger about so many changes happening within the dental industry and this level of uncertainty, and where is this change coming from, and this lack of sense of control over your environment.
I mean, it takes a big person to just step back and realize like, this isn't all me. This is like the environment or the climate that we're in right now. But you're in a unique position with this because you're a hygienist, you're a proud hygienist. And
Mm-hmm.
I'm just wondering, like, when they pass this legislation for assistants, what was your initial feeling about that? Like, were you supportive of it? Were you kind of questionable?
Well, I will say it is not through legislation.
Oh,
It was
okay.
through the Oregon Board of Dentistry.
Okay.
So like, I just want to make sure it's not a law. It is a ruling that the board put out.
Gotcha.
Now, like I said, I've been involved in this conversation off and on for 10 years. And my first step into being involved in the conversation was a group of dental hygiene students that were getting ready to graduate from their baccalaureate dental hygiene program, a program that I was not involved with in education. Like I didn't teach there. Their capstone project was, what would it look like for a dental assistant to administer local anesthesia? These hygienists were dental assistants prior to entering dental hygiene school. And because of my role in the dental hygiene community, like during that time over 10 years ago, and with my passion of anesthesia, I was asked to be one of the members of their advisory committee for their capstone project. And it was a variety of dental professionals within that: oral surgeons, dentists, dental assistants, other hygienists. And so these hygiene students were very much in support of having this move forward. And if it did, what would the whole educational curriculum look like? So I had an opportunity to have a very non-invasive thought process to it, because I'm like, oh, I'm helping these hygiene students come up with what would that look like, and pushing back on some of the thought processes. And they actually submitted it to the Board of Dentistry, I believe, like over 10 years ago, and it lost traction. And then a couple of years ago, so it lost traction, COVID happened, and then, a lot of things lost traction. But then a couple of years ago, a couple of very passionate dental assistants that are part of the Dental Assisting Association, they heard conversations about this coming back forward within the dental community. And they were like, if this is coming forward, we want it to be an elevation of the profession. And so it's the highest standard possible. And they reached out to me. They're like, okay, Tina, you were involved with that group. You do certification courses across the nation for hygienists. If this were to happen, what do you think the education would look like? And I was like, this is what I think. And I was like, I interviewed different dental assisting educators, fill me in. What's the process? What do we need to know? And I submitted a plethora of information saying, if this happens, this is what I, as Tina, think should happen as far as education on general anatomy, head and neck anatomy, human physiology, medical emergencies, all pharmacology, all the way through just how you hold a syringe, like everything through that. And they have to have graduated from this specific type of educational platform and take a board exam and do all these things. So I sent that to them. They reviewed it and they submitted it to a committee with the board or something along those lines. After that point, I wasn't really involved in the conversation. My understanding, and again, this is just my understanding, is that committee took that information, they worked with it, took it to the board. It was workshopped, whatever. And then the board made a decision in November saying, if the curriculum looks like this, then they decided to approve it. I was kind of shocked. I was like, wow. And they actually diminished a lot of the recommendations that I had put in there. Like, if it happens, these things need to happen. Come to find out that some of the other organizations that were pushing for this, they submitted education that was less, like 21 hours worth of just
Total
education and different types of things. So I was like, you know what? I will be a part of the conversation, put this out there. If it does happen, this is the kind of education that needs to happen.
Mm-hmm.
And I'm really grateful that I did, because had it not, the educational standards might have been a lot different if it was coming from some of the dentist organizations. But the dental assisting groups were like, we want to elevate our profession and make this better. So yeah, it was a very interesting process.
And what, I guess, as far as like why this came to be, what is the motivation? Like they just want to learn more things and elevate their profession, or are dentists like, I need help with anesthesia, maybe this is something that can help?
The main motivating factor is back in 2008, dental hygienists and dental assistants in the state of Oregon were given the rights for restorative care. So the doctor prepares the tooth, and then the hygienist or the assistant can come in and place the restoration. So that was moving forward, and a lot of dental offices that had adopted that found that it wasn't working, that restorative model wasn't working as well when they were having the assistant coming in and doing it, because then the doctor would have to come in, anesthetize, then the assistant could place the rubber dam, do all the things, all the prep work, and then the doctor would come back and prep the tooth. So it made a lot of multi-points, or they would have to have a hygienist come in and anesthetize. So the motivation was for on the restorative side of dentistry to help streamline patient care processes, is my understanding as far as that aspect. It has nothing to do with now assistants are going to be doing more in the hygiene, preventative therapeutic side. It is how can they assist on the restorative side more, especially since they've had the restorative endorsements for coming on 13 years now.
Okay. I get the thought process there. So just for people who aren't familiar, if you can just tell us like the level of these assistants, like what education they've gotten. You already kind of touched a little bit on like the actual curriculum. And then do they have to pass a board exam or Yeah,
no, good question. So the Oregon Board of Dentistry said that dental assistants do not need to take any type of additional examination after their courses. It's the same thing for dental hygienists in the state, where dental hygienists in the state of Oregon do not have to take an anesthesia board exam in order to have their anesthesia endorsement. Every single state is different. There's actually a lot of states in the nation that do not require a dental hygienist to take a board examination in order to administer local anesthesia. I think that's important to understand. Yep. That was something that the Board of Dentistry, they did not put that in place. I think there were quite a few people that were like, oh, even myself, I was like, oh, okay. Yeah. So as far as additional testing out of the certification course, no, that is not required. Is it recommended? I would say do it. You never know what's going to open up. As I tell my hygiene students, you never know where your footsteps are going to take you. And if you end up going to a state that does require that, and within dental assisting, I do think that you've got 2 states that are doing it. And if they decide to go to Minnesota, I believe they have to have that. I believe. I can't quote what's happening in Minnesota, but that is something that could potentially be something that will help them get to that next state if they want to go to another state in regards to anesthesia. Other things that dental assistants in Oregon can do, restorative, after they take a course. When you look at the Oregon Board of Dentistry website, there's 2 different levels of anesthesia assistant, and actually dental assistants have been doing general anesthesia for a really long time. Local anesthesia is the newest one. And I saw a very popular social media person. He was talking about it, and he had the Oregon Board image behind him, and it was actually for the general anesthesia post. And I was like, that's so funny. I was like, you grabbed the wrong one. That's about general anesthesia. Yeah. So dental assistants have been able to administer general anesthesia for quite a few years. That was one of the things when I was personally wrestling with this idea, is looking at what can an assistant in Oregon do. When I reviewed that, I was like, okay, wow, that's even more intensive than local anesthesia. Yeah. So they can do that. Sealants, place sealants, take radiographs, supragingival scale on pediatric patients. That has been in place for as long as I can remember. I've been a hygienist here in the state for 25 years.
And these are FDAs, right?
Yes, all FDAs.
Okay, got it.
Yeah. Okay. Yeah. So like you can be a dental assistant on the job trained in Oregon, but if you want to have these expanded practices like being able to place a cord or anything, being able to take radiographs, being able to place sealants, you have to do these extra items. And if you want to have your expanded functions, you have to go through a curriculum and process through that way.
Because I think that's where people started freaking out, is because they thought it was on the job, and then we're just giving them a needle and, letting them just go at it. But it's not like that.
Right. Yeah, no, there's a lot of different levels. And that's one of the things that really frustrates me about the dental community in of itself, right? In the role of a dentist, you can have your dentist, but then when they decide to specialize, you're an endodontist, you're a periodontist, you're an oral surgeon, you're a prosthodontist. Like there is a name for that specialty. When you're a dental hygienist, we have a lot of varying roles, but there's no special designation. Like you can be a restorative dental hygienist, or you could be a expanded practice dental hygienist. Like you're still a dental hygienist. Mm-hmm. The same with a dental assistant. You're called a dental assistant, but you can be a dental assistant and come in from McDonald's and like, okay, hopefully you got at least some infection control, put some gloves and a mask on and sit chair side and hold the saliva ejector and rinse. You can be called a dental assistant. And you can also be called a dental assistant after you've gone to a CODA approved program and you've received all of these certifications and expansions, and still be called a dental assistant. And for me, if I were a dental assistant, I'd be very, very sad that if I had all of those extras, that I was still called a dental assistant when somebody else can still be called a dental assistant.
Yeah, dentistry is weird like that. You're right. And I remember when I first moved to Colorado, I learned how lenient the Practice Act is here. Not lenient. I don't know if that's the right word. Progressive, whatever.
Expansive?
Yeah, I guess. But it's like the Wild West, because assistants, they can be on the job trained. They can also become an ETA, and I'm putting that in quotation marks because that means something different to different people here. But they can just get on the job trained, and then all of a sudden they call themselves an ETA. So it's like, if I run into someone and they say they're an ETA, I don't know what that means. I'm like, did a dentist teach you? Did you go to school? Because some people did go to school, but it's like they don't have to. So it's really weird.
Yeah. It's kind of like is it Arkansas or Alabama. I always get it confused which A state it is where there's preceptorship for dental
Alabama.
hygiene. And so it's kind of like, but they have the licensing designation of that. So does that mean we shun them in the dental hygiene community, or do we embrace them and say, okay, you took a very different controversial educational path. Now you're there. Let's make sure you have high quality education for that patient.
Yeah. Yeah, I know it's all over the place. And
Yeah.
just real quick before we move on, because I know you've got some really good tips on actual anesthesia for people today. But as far as
Yeah.
your certification with these dental assistants, it's not
Yeah.
just anesthesia techniques, right? What else are they learning about?
It starts off with basic human anatomy.
Okay.
Like, what is the heart? What's the function of the heart? The liver, the function, like, why do we want to know about these things? Right? It starts with basic human anatomy, then goes into head and neck anatomy, then into pharmacology of local anesthetics, talking about patient evaluation, health history review, all the questions you have to ask, medications. How do you look at medications? What does that mean when we're looking at these medications? Cardiovascular dosaging. What is the impact of vasoconstrictors with our anesthetics? Pediatric dosaging, elderly dosaging, like going through those entire aspects. Medical emergencies. Like, I'm very passionate about medical emergencies. So, medical emergencies, how do you identify them? How do you take care of them? How do you treat them? And all throughout, like, they have case studies that they have to like review and write answers on. They have quiz questions after every single module. There's a lot of work that they have to do. They get a skull where they have to draw the nerves on the skull and submit all of that work to me for me to evaluate, give them feedback going, okay, let's look at this, look at that. Like, there's a lot of work. It's not just a independent, oh, I watched the videos and now I showed up, right? They have lots of assessment points and examination points along the way throughout the entire process.
And it was a multi-month course, right?
I always recommend to everybody, I was like, you're going to want to give yourself 2 to 3 months to go through this.
Okay.
Now, I have had people who are like, I just took, like, I had one woman, she was like, I took a week and a half off from work so I could focus on all of this education. So she did a bulk of it during that week and a half where she dedicated like 5 hours a day
Oh my God.
going through all the course material. So that's a lot. Like, think about, like, when you were in school, if you dedicated 5 hours a day to one topic, that's a lot of time.
It is. I don't even think I could do that now. Like, I don't think I have the focus for that now.
Right. The students have to go through all of the lecture aspects of it before they can even pick up a syringe and do the clinical aspects of it. And they have checkpoints after checkpoint after checkpoint that they have to do. And then when they're in the hands-on portion, we have skill assessments that they have to complete. So yeah, it's a college level course.
Yeah.
It's definitely a college level course.
Well, and that was another thing that I was seeing online, that people thought it was a weekend course. And I'm like, guys, it's not a weekend course. Like, dig into it a little bit,
Yeah,
you know?
the clinical aspect is in 2 days. And we have to think about, like, in reality, we have to remember, like, these are also working professionals, and to be able to have 1 hour a day where they come in and do one injection and then go home, that's not feasible.
Yeah.
And all of the educational entities in the state of Oregon who are doing it are doing the clinical aspects in a weekend. Okay, so that's not unique to this particular educational program. I just happened to be the very first one in the state to have it going, but there's several entities in the state that are having this educational program. And I will say the hours of education vary from entity to entity. So the Board of Dentistry said the minimum hours is 50. So there's some curriculum out there that is 50 hours. And then mine, I think, is the highest, which is 65.
I'm still like not sure how I feel about all of this, but I am very thankful that you're one of the ones instructing them, because I know how good of an educator you are. And it's like, okay, if this is happening, which it is, and I think that it's going to continue to happen, we need someone like you to make sure that they're competent. So anyway, I appreciate you. And I'm just sorry that you experienced all of that on social media.
As I was saying before, like, it was a really good personal growth moment to be able to go, okay, while I know that not everybody is on board with this, it is here.
Yeah.
And am I able to put my head down at night? Absolutely. Because if somebody was like, I hope you don't teach ethics. And I was like, what is more ethical, to stand by and watch it happen and then see education that maybe I don't agree with, or that the community might say, why is it only that much? Or to say, you know what, it's happening. Let me stand here beside you and provide you with the highest quality. Because for me, this personally is an extension of patient care. Like, and I tell every single student that goes through it, I was like, I'm so happy to be here for your professional growth. But when it comes down to it, it's your patient that I care about most. So if you can't do this without being safe for your patient, then this is not the path for you.
Yeah. No, it's so true. Okay, cool. So we are going to switch gears here because I just want to
Okay.
pick your brain about anesthesia. And I don't think I've ever told you this, but I failed my first anesthesia board in school. I remember it very clearly. I got a positive aspiration and that was just an immediate fail, which I was kind of like, what? Are you serious? They like told me to stop anyways, but I just had to like pay to take it again. And then I passed. But anyway, it was scary.
Right.
And giving injections for some people is scary. So what tips do you have or advice do you have for people who might be intimidated about giving injections?
Yeah, well, one, there's nothing wrong with being overwhelmed, intimidated by the process, right? It is, especially if it's something that you don't do on a regular basis. It's like anything else. Like if you're not riding a bike all the time, like the first time you get back on a bike, you're going to be like, where are the cars at? What's going on? Am I safe? Am I steady? So if you're unsure about it, what I say is just keep going to CE courses, see if you can get into a hands-on refresher course, review your anatomy, make sure you understand where the nerves are, make sure you understand where the blood vessels are, what are your bony roadblocks, all of those aspects. Make sure you've gone through and done a deep dive on understanding the patient's health history. And I have to say, I really want to challenge everybody that listens to this. Please take your patient's health history seriously, because that's going to be the biggest concern down the road in regards to anesthesia, is not understanding your patient's health history, their medications and their health status and what we do with that. So if you can confidently understand someone's health history and make ethical clinical decisions based on that, you will avoid a majority of the scary moments that can come along with local anesthesia. So I would definitely say, please do that. And honestly, it just comes into taking that step and being brave enough to say, okay, well, maybe I don't feel comfortable with the block, but I can feel comfortable with doing some like supraperiosteal infiltrations kind of a thing, just to get yourself back into the idea of putting a sharp pokey thing in somebody's tissue.
Yeah, it's like a big deal. I remember when I was a newer hygienist, maybe, I don't know, the first 5 years out of practice, I would get kind of clammy, a little sweaty every time I'd give an injection. And it's funny, like hopefully reminding our patients to breathe while we're giving the injection, but we need to do that too, because I do
Yes.
assessments and I see a lot of clinicians giving injections and I can tell they are not breathing. They're just holding their breath the
Yeah.
whole time.
And it's so true, because, and the thing is like when we are tense, that transfers to our patient. So if we're like talking to our patients and we're saying, let's do some relaxation items, let's do some deep breathing, you can do those box breaths, and there's other different types of breathing relaxation techniques. But when we guide our patients through that helps us. The other thing is when we guide our patients through breathing techniques while we are doing our injections, that can also help us. We could guide our patients through some visual, I don't know if meditation is the right word, but just kind of get them to be thinking about somewhere else. Like, where's your happy place? Before we even give the injection, say, okay, if you could be anywhere else than the dental chair, where would it be? And for me, I'd be like, it would be toes in the sand, palm trees swaying, ocean breeze going, like, put me there.
Yeah.
And so we can do that for our patients. If they say, oh, it's walking the trail along the Pacific Northwest, then it's like, okay, well then let's go there. Like, I want you to visualize the trees and the smell of that damp earth and the leaves crustling under your shoes as we are sitting there inserting and aspirating and slowly depositing.
Yeah, visualization is really important. And I think a
Yeah.
lot of us too, as clinicians, we are extremely empathetic, whether or not we're quote unquote empaths. And so I know me, if my patient is super keyed up and anxious, I feel that. And so if I can calm them
Yeah.
down, it's also going to calm me down.
Right. And the other thing too is I think it's important to expand your arsenal, so to speak, in your injection approaches. So, you might have a patient that's super anxious. They won't open their mouth. Their tongue is 20 times bigger than their mouth. All of a sudden, it just like was like a sponge and expanded, right? And it's like, okay, so what else can we do that might be a little more non-invasive? Have you explored using an achinosis technique, the Vazirani achinosis technique, which is a more closed mouth relaxed technique, which from the patient's perspective is really, really, really nice. From the clinician's perspective, it can be a little unknown because there's a steep learning curve that goes along with it. But when you master it, it's a beautiful option out there.
So that's something I wanted to ask you about was alternative techniques that you wish people did more of.
Well, I would say that the textbook IA is too low.
I agree.
It
I
really
always
is.
go high. Always. I'm like way
Yeah.
higher. Okay, good. I'm glad you said that.
Yeah. So if you are like a true blood inferior alveolar person, you're like, that's the injection for me. The biggest error I see with that is everybody inserts too low. So just hug that raphe and move your needle. I always say move your needle superior or up. And sometimes when I do that, people will go out into the buccal mucosa a little bit. Like up is different.
Yeah.
So move towards the maxilla.
Got it.
Move towards the maxilla, but stay close to that raphe. And I've got so many hints and tips, but like there's this cute little triangle that really does develop in the mouth that you can see. So aim higher, just like our goals in life. Aim high, and you'll get it right. So there's that. And I also just think that people need to explore alternative mandibular blocks like the achinosis, which is a very nice relaxed closed mouth technique. It's very atraumatic to our patients. The struggles behind it is the ability for the clinician to totally see like how deep they have inserted the needle and maintaining that angulation. But when you do it, it's great because we're just basically doing a flat, I call it a flat PSA. You're inserting at the same spot, but instead of with a PSA, right, we're like this. A VA is you're going straight back and you're aiming more towards the mandible instead of the maxilla. So hard to describe on a platform like this.
I know, but you've got a course, right? And I imagine that you talk about that. Yeah. Is there any bony contact with the achinosis?
Not with the achinosis. That's the one mandibular block that we don't have any bony contact with, but the IA or the Gaugates. The Gaugates is another great injection. It can be very intimidating to some because we are going a lot higher, aiming towards that neck of the condyle, right? Here, I just happen to have part of my little skull. So we're aiming here.
Okay. Right, yeah, that is a lot higher.
Triangle. So we're aiming there for the Gaugates. So it's a little bit higher. So that can be a little intimidating for some people because your bony contact is a little bit more narrow. However, if you can master it and you get really good at it, you'll get profound anesthesia really, really well.
And the logic behind using a Gaugates versus the IA is you don't have to also give a long buccal then? It numbs everything? Okay.
Right. Yeah. So you're hitting that mandibular nerve higher up on the chain. And so you have, if you think about your nerve like a freeway, right? And you go from like, I'm on the West Coast, so I-5 is our big freeway here. So as it's traveling down the medial portion of the ramus, there's little exits, nerve exits, little road exits that come off, and that nerve just starts getting narrower and narrower and narrower. So when we can anesthetize that nerve higher up, we have the opportunity to block that communication before those other nerves branch off, before the mylohyoid nerve branches off, before the long buccal nerve branches off. The lingual and the IA nerve sit really, really close to each other. So it's really hard to miss that lingual nerve. Yeah. But to be able to get both of those at the same time, it makes life a lot easier.
Okay. I've had the experience where, cause I'm kind of a high IA giver, I guess.
Yeah.
And
I call it a hybrid technique.
Okay. I'm like, this is where they taught me to go. I'm going to go higher than that. But I've had the experience too, where it's like, let's say I give a lower right IA and a long buccal and everything's fine until I get to a freaking premolar. And then all of a sudden they are not numb in that spot.
Yeah.
So why is that? And what can I do?
It's anatomical variation for that patient. And it can be the first molar or the second premolar, it really kind of depends. But oftentimes it's that mylohyoid nerve that branches off the mandibular nerve. and goes down into the mylohyoid muscle and into the glands in that area. Sometimes there can be a little accessory innervation of a little nerve that pops off and decides to provide bonus anesthesia to that nerve. So things that you can do for that is, of course, we go higher. So you get that branch before it breaks off. But oftentimes you're already going and it's on that one tooth. So what you can do is just some lingual infiltration, or you can even take Articaine. Articaine is beautiful because it penetrates that thick mandibular bone so well because of its chemical formulation that you can even maybe do some papillaries right along that particular tooth, and it will get around to that lingual area as well.
Speaking of Articaine, I love Articaine, Septocaine, whatever. Can you put this myth to rest that we aren't supposed to use that on the lower?
Yes, this is the sad thing that happens with misinformation, right? And I think that, we will see this forever in our days. There was one study that came out when Articaine first arrived on the market. It was a flawed study, and it was a small study that said paresthesia happens with the use of Articaine. And of course, with anything else that's new on the market, there is this, oh, this is new and we're seeing these things happen. It must be that. And the entire theory of Articaine causing paresthesia, there's been a lot of research on it. It's been debunked. The rate of paresthesia is no different than Prilocaine, honestly, and statistically, it's very insignificant. Usually, like if we're seeing paresthesia due to a medicine, which is a chemical, we're going to see that happening on all the nerves. It's not just going to be, oh, well, I really like to only cause paresthesia on the lingual or the inferior alveolar.
Yeah.
Those are the only nerves I will ever do this on. All the other nerves are totally safe, except for those two nerves.
Makes no sense.
It's not that strategic.
Okay.
The other thing that I think we have to remember with paresthesia is that majority of the time it's due to the clinician and not the chemical.
Like technique?
Yes. So, you do a lot of assessments and you see a lot of clinicians giving injections. And I'm sure you've seen some clinicians that I call it a sewing machine where they use their syringe and they end up going like this, turning their patient into a little sewing machine, right? They're like, oh, I've contacted bone. I've contacted bone. I've contacted bone. And every single time that needle contacts bone, it goes like this and barbs and this and barbs and this and barbs. And so pretty soon we have turned our beautiful straight knife-like beveled edge into a fish hook. And as we withdraw, now we're going to be nicking blood vessels. We're going to be nicking nerves, doing all of these different kinds of things. So it comes down to clinician technique more so than the anesthetic formulation.
Interesting. Okay, good. I'm really glad you said that because I love Articaine. I'm like, please don't make me stop using this.
I'm a member of the American Society of Anesthesiologists, the ASA. So when we talk about ASA classification, it's an American Society of Anesthesiologists. It's their classification that they've put up to see how well a patient can tolerate anesthesia, whether it's general or local anesthesia. And one of the blessings of being a part of that group is I get to have access to a lot of their research articles.
Okay.
And many of the anesthesiologists and medical professionals have adopted Articaine for medicine because of how quickly the body metabolizes it, how safe it is for the internal organs, and the patient's ability to return to normal function afterwards.
Wow, that's really cool. I didn't know that. I'm glad though, because I've given injections for the dentist numerous times. They come and ask me, usually I write it down, but if they have a question, they'll ask me like how much I gave them. And I'm like 1 carp of Articaine. And sometimes their eyes get huge when it was like on the bottom and they're like, you used Septocaine on the lower? I'm like, yes, it's fine. And they're just like, I'm like, just I'll put my name on it. Like if anything happens, but it's not going to, it's fine. So hopefully we can get over that at some point.
Yeah. And I think that what I'm seeing through the years that I've been teaching this and educating and doing CE courses is I'm getting less and less questions on that the word is getting out. Good. That it's okay. The rest of the world uses it all the time. And the United States is slowly catching up. And I think we can all agree that Stanley Malamed is kind of I call him the godfather of local anesthesia, right? Like he's the true pioneer that us as dental professionals go to understand local anesthesia. And he's been professing Articaine for like 15 plus years with the use of mandibular blocks. So it's been out there for a long time.
Yeah, but that's how misinformation works, right? It's like it freaks people out and then we can't forget it. Okay, so when we're talking about patients, you already gave us a tip as far as the achinosis for patients who can't open. Do you have any other tips for patients who can't open very big during injections?
So it really depends upon which injection you're
Hmm.
doing, right? For our maxillary injections, it's pretty easy. We actually want them to be closed
Yeah.
a little bit. If you are working with somebody, and again, it depends upon what's the procedure that you're doing. An echinosis is a great one for people with limited mouth opening if you're trying to get a mandibular block. You could also go in and do like bilateral mental incisive injections, to get really good premolar to premolar, canine to canine anesthesia, and go back through and do mandibular infiltrations if you need to. Just remember, if you're doing that, you need to use something like Articaine, because some of those other anesthetics, you won't achieve as profound anesthesia because it doesn't have the chemical formulation to penetrate that thick cortical bone.
Do you recommend people use a bite block? Like if they're giving an IA? I worked with a doc, he would always put that in before he'd give the IA. And I'm like, I wonder how that is for the patient.
I would say if that works for you,
Okay.
great. Just make sure that you position your bite block in such a way that it doesn't inhibit you from having proper ingulation for your injection. There's nothing wrong with that. And oftentimes people like the gow gates, right? That one is we have to have the patient open really wide. So having a bite block to prop their mouth open could be very, very helpful. I would just say, like, there's a lot of sizes of bite blocks in there. Some can be very narrow. Some of them are like, oh my gosh, how do you even fit that
Yeah.
in the patient's mouth? Just make sure that it is positioned in a way where you can actually get your barrel to the opposite side of the mouth where you need to be. Maybe you put the bite block on the side that you're injecting, as long as it's not obstructing your view and still giving you the ability to maintain your insertion and deposition site.
Okay. Yeah. What about big tongues? That I've
Yeah.
wrestled my fair share over the years.
Yes. Well, if you're a solo clinician, I'm going to say honestly, there probably isn't as much that you can do. You can sometimes come in, and I'll just look at this. Here we go. I'm going to leave the cap on my little needle here. So sometimes, like, say if we're doing my brain will not go as this is the right or the left IA right now. So say we're doing this IA, right? So instead of coming all the way in like this, we may start here, but before inserting, like getting to where we want to go, is then slowly bringing the barrel over the tongue so that the patient feels that barrel moving things. But you want to make sure you do it before you insert so that you don't end up bowing your needle. Because if you come in straight across like this and then come over, you're going to turn your needle into a nice little rainbow. And then you have an opportunity to have like a whiplash moment and cause some internal trauma to
Okay.
that area.
But probably the best is like getting an extra pair of hands, right? I've had to do that
Yeah.
numerous times. So just have someone retract
Yeah.
for me.
Yeah, and make sure that they've got like a mouth mirror, something that's a little stronger and stiffer to help hold the tongue down. Sometimes even a saliva ejector. And also sometimes what it is just that the topical has created such a strong salivary flow, and now they're really salivating, and so their tongue is trying to keep their saliva from going down their throat, so it starts to pool back there. Sometimes it could be something just as simple as really clearing out that area, rinsing the mouth, letting them have like maybe 30 seconds between the topical being removed and the needle coming into the mouth is not going to make or break your injection. Just to give them a moment to reset their taste buds and their salivary flow. Like having somebody even having the suction in there might be enough to keep their tongue down. And I will say, like, how many times have you told your patient to like move their tongue or not think about their tongue, and then their tongue is even worse?
I try not to even say the word tongue because it
Right.
gets crazy.
It does. It does. It really, really does. Yeah.
Yeah. Whenever I hear of clinicians being like, okay, relax your tongue, I'm like, good luck with that. It's not going to be relaxed.
Yeah. No, you just say, okay, close your mouth.
Yeah. Yeah. Right.
Not open.
What about patients who, I don't know how to say this nicely, freak out during an injection when you're deep in the tissue and they have a reaction? Like either they're touching you, they're
Right?
slapping you, or they start crying or screaming. Like I've had it all. So how do we handle that?
Yeah. My advice in those situations is, one, we have to prepare a patient ahead of time. Just to say, this is what we're going to do. You may feel a tingle through your lip. You may feel a tingle through your tongue, especially with our mandibular blocks. When I first start depositing, you might feel some stinging sensation. Just giving them the heads up of what they may experience and that those are normal items to experience. Okay. I think we should normalize that
Okay.
for sure. Also, having a communication method set with them ahead of time, like if you need me to pause or stop or anything, like rehearse this. I want you to raise your left hand or your right hand, whatever side that you are not on, or come up with some sort of signal so they know that they need a moment, I think is very, very helpful. The other thing is for us personally to recognize that that is something that patients are going to do and that we have to be strong enough and to know like I'm right where I need to be. I just need to get this going and just to talk them through it. Like, you're doing great. We're almost done. That sensation should stop soon. I know that that's uncomfortable, but it means we're right on target. And try not to rush your deposition because rushing our deposition can actually make a situation worse. So just really trying to talk our patients through it. What have you found have been some things that have been helpful for you?
Well, I usually start by we have to have some kind of emotional intelligence, right, with our patients and realize and be like, okay, this is a patient that would probably do best with less information, or this is a patient that probably wants to know every single thing because I have made the mistake where I give someone who probably doesn't need all the information, I just vomit everything at them and I can just see their anxiety going up. And I'm like, I probably shouldn't have
Yeah.
done that. So kind of judging what kind of patient you have too, but making a joke out of it. I try to make a joke out of most things in my life, but with that shock, that lingual shock that people get and be like, you might feel like an electric shock go through your tongue. That's actually awesome. That means I'm in a good spot, so just like ride through it. And they're like, okay.
Yeah.
But if they don't have a heads up, that can be a really uncomfortable thing to feel.
Yeah, it really can. And I appreciate what you said about having that emotional intelligence, or even just saying, like, asking your patient straight up, like how much about what I'm about to do you want to know? Are you ignorance is bliss, or do you want to know the details?
Yeah.
Yeah.
Yeah, I think that's good. Speaking of topical, I wanted to pick your brain about that. I've used Orachix, Cetocaine, Gingicaine, and most of them are work pretty good. But what's your opinion on those?
They all have their purpose. Like, they all provide different benefits. There's a lot of clinician preferences through all of them. The nice thing about like Orachix is that it's lidocaine and prilocaine, so it's an all amide based anesthetic, so lower incidence of allergy.
Okay.
Right? Which is great. I will say, it is more expensive than some of the other ones that are out there on the market. And, a little goes a long way, but it is a great option for our patients where we're concerned about ester allergy. Cetocaine, I think, is wonderful because it's a combo drug, because you've got benzocaine, tetracaine, and butambin all mixed together, which are all ester drugs, but you have like a combo, like 1, 2, 3, like you have a short and a medium and long lasting anesthetic. They try to make it taste good with banana, but I don't know.
I don't know.
So I think that's a good option. A lot of people get really profound anesthesia, even some pulpal anesthesia with it. And so I think it's a great item. And then what you said, gingicaine, like that's just straight up 20% benzocaine. It's just delivered in a way where we can put it sub G. And again, that has its time and place. I think there's a lot of different companies actually now that are providing that. It's not just gingicaine, but there's a lot of different kind of modalities with it. It makes it pretty easy to apply. You can use a little bit more. Benzocaine has a little bit more of a flexibility in dosaging than maybe Cetocaine, because Cetocaine you can only use such a small little amount. So like if I'm doing like strong scaling in the presence of inflammation and I need some soft tissue anesthesia, I'm probably going to grab my Cetocaine first.
Okay. And I like of course, look at everything with an ergonomic eye. And I like the Cetocaine and Gingicaine syringes because they're nice and small and I can adapt them. The Orachix, I don't know, maybe it's me and my hands. I don't like the applicator. It's very awkward for me. And it just, I don't know, it's not comfortable.
Yeah, it's kind of like, do I use my fingers to click or my thumb? Like, how do I, and we're so used to so many things in dentistry that are that plunger syringe style, our composite, our etch, that it is a very natural kind of a flow for that, for sure.
Going back to ergonomics too, I know there's different syringe types. Like they're not all the
Yeah.
same, right? So is there one that's your favorite, or does it depend on the clinician?
It really depends upon the
Okay.
clinician. And at one point in time, I had a variety, like a rainbow of syringes
Yeah.
sitting here at my desk. But I only have two sitting here with me right now. But yeah, there's a lot of different ones. It just depends upon the clinician. It's just like shoes, right? Like I might really like to wear Brooks or Nike or Asics, right? It just really depends upon the way your hand is, how long your fingers are, how broad your hand is. And, you could have something like a very typical, this is like our very, very traditional syringe.
Hmm.
There you have these little wings here, which some people really like because you get some extra
I
support.
like those.
Then there's some, and of course I don't have it here with me, that looks exactly the same, that don't have the wings on there, which allows you to have a little bit more freedom and motion with that. Some people don't like those wings.
I like the ones that have the wings, but like have
Yeah.
like silicone like grippers on it.
Yeah.
Yeah.
Yeah, and some of those they're like, you can even get those where they have the round or they have the oval. Like, see, like this one's kind of an oval shape
Oh yeah.
thumb ring. So when you have that oval shape, it makes it a little bit easier to get your thumb in there and aspirate. But yeah, that silicone grip is nice. I think there's a couple of companies, Miltex and Dent Supply, I think, that have those out there. And pretty much every instrument company has their version
Yeah. Yeah. And
of
I know
syringes.
that, I mean, when I open the drawer at my office, because there's a bunch of different syringes, I always am rooting for the one I want. So I figure other clinicians are like that too. We get kind of
Yeah.
picky.
Yeah. And, I get a lot of questions too, because sometimes clinicians don't have that opportunity or that flexibility to pick all of the instruments that they're going to be
Hmm.
using, right? And sometimes they'll come in, especially if they're a guest hygienist where they're coming in and helping out for a day or two. You get what the office has.
Yeah.
So, like somebody like me, like I have really tiny thumbs. Like I stick my thumb in here and I've got room for days, right? Like
Yeah.
there's so much gap through there that, like, how do you make that work for yourself? And I don't have any 2x2s here, but like oftentimes what I'll do is I'll just take a 2x2 and wrap it around that thumb ring to create a
Oh,
little
that's a
bit
good
of
idea.
cushion in there, so that way I can aspirate. Like when you were a little kid, and I don't know, I did this. I would put my mom's high heels on and I'd put a whole bunch of
Yeah.
tissue paper between my heel and her heel so I could try to walk around in them, right? To close that gap. It's kind of like doing that for the thumb ring.
Yeah. Oh my God. That's a cute analogy. Okay. Let me just say, I used to do this too before I learned ergonomics, and I see this with my assessments, but I see a lot of, and if people are listening, I'm doing a crazy like chicken wing thing right now, but I see this
Yeah.
a lot when people are giving injections and they're like this. So what advice do you have for being ergonomic?
I have found that for me, and when I'm coaching other people through injections, when we stand, we tend to be a lot more ergonomic because we can get closer to our patient and we have a little bit more flexibility with our trunk rotation.
Mm-hmm.
But it's really kind of crazy to think, but the angle of your trunk, of your core, can really make a difference on your capacity to do your injection. So sometimes with my students, I'll say, pretend there's a flashlight coming out of your navel. Think about where that flashlight is,
That's good.
and that's where you want it to illuminate the area that you're working on. If your body is facing the patient's shoulder, but you're trying to go up into the maxilla, like you're going to have to like do some kind of funky twisting and moving around. But if you can stand up, be close to your patient, rotate your body just right, and have your elbows really tight to your side, you can get some good stabilization.
Yeah, I love standing. And I mean, if you're, doing this crazy thing, like your muscles are going to start getting tired very quickly. You're probably not breathing. If you start shaking because your muscles are so tense, like, are you giving it a good injection? Like, I don't know.
Right, right. Well, maybe like the wiggle of the
Yeah.
hand might be a nice little distraction technique.
Yeah. Does that work? I do it and I think it works, but I don't know.
I think it's a clinician preference.
Okay.
I haven't seen any research that supports it. I haven't seen any research that refutes it. But if it works for you and if it helps your patient, great. I will say this, with a novice clinician or somebody that doesn't do it all the time, it's kind of like rubbing your belly and patting your head at the same time. It's like you're shaking this one and then you're doing this. You're shaking both hands.
It's probably not
right?
good.
So you kind of have to get used to like moving one hand and being very, very steady with your syringe hand, and also knowing when to shake, like pausing long enough when you get to that insertion so you're not lacerating the tissue, shaking that all around the needle. when you go through. I've seen that a lot of times where people are like really aggressive with the lip wiggle, and then they go to insert and you can see like this little kind of little laceration mark from when they inserted the needle and we're shaking it a little too much
Oh,
through that
okay.
area.
Yeah. Yeah, that's true. What are your thoughts on the Synapse device?
I think that the Synapse device has a beautiful place in pain management in regards to post pain therapy for like ortho, whitening, TMJ pain therapy. I've tried it with like for pre anesthesia, like for paddles, the amount of time that you need to put it on the hard palate in order to anesthetize. For me, like if you have to have it there for like a minute, like
It's a
rubbing
long
it along the
time.
palate for like a minute. For me, I find I would much rather just apply my pressure anesthesia and inject instead of taking that minute. But that's for me. I've seen clinicians have a lot of success with it with restorative and other perio aspects. Maybe I wasn't doing it 100% correctly. I don't know. I know you and I have talked about this, but I haven't seen personally the success with that like I have with post treatment pain management.
Yeah, I agree with you. It's been a few years now that I tried it, but I was like, am I not using this right? Am I not using it for long enough? Like I just wasn't getting the results that some other clinicians were. And I remember when I was learning about it, it was like 30 seconds per tooth or something because they were talking like, oh, you can do it for probing and have pain-free probing. I'm like, I don't have time for 30 seconds per tooth. Like, no, I'll
Right.
just rub some topical on there and call it a day. Like, let's go.
But it is nice for our patients that don't want to have that chemical aspect of it. So just like anything that has its time and place. So you have to kind of make that decision for yourself as the clinician.
Yeah,
Yeah.
it's nice to have options. I mean, the more tools we have in our toolbox, the better. What about
Yeah.
buffering? I know
Oh,
you
yes.
love
I'm a
that.
big fan of buffering. I love it. I love it. I really think that we're going to see this more in dentistry. Medicine has actually been buffering anesthetics for a really long time. They have been doing that. Like, that's just their standard almost protocols anymore is to buffer their anesthetics. I think it's wonderful. There's two companies that you can have it pre-made for you that are available on the market, Onset and Buffer Pro. Onset is its own, I think that's through On Pharma. No, I can't remember. And then Buffer Pro is through Premier. So those are nice because they're already pre-measured and all you have to do is quickly put it into your anesthetic cartridge. There's a lot of offices that will just buy sodium bicarbonate from like their compounding pharmacy, or I've even heard of some offices making their own. I think that some caution needs to be seen with that. While making your own or going to a compounding pharmacy is a lot less expensive, you just have to make sure you're dosing it correctly so that way you don't over buffer your solution.
Oh, okay.
And you also have to look at the expiration date on your buffering agent because just like anything else, it does have an expiration date. So
So, for those who don't know, just quickly tell us what buffering is and what the logic is behind it.
yeah. So what buffering is it takes the anesthetic solution, which is very acidic, especially like if we take something like 2% lidocaine with 1 to 100, like that's our standard anesthetic really anymore in dentistry. It takes it from a very acidic pH of like a lemon, which is like about 3.4 ish. Sorry, I don't remember the exact pH. And it brings it up to a more neutral solution. So closer to like that 6 to 7 aspect of it, which our body sits at 7. So when we buffer our anesthetic, one, it takes the sting out of the anesthetic. So for our patients, it feels a lot more comfortable. But the clinical benefits of it is that that anesthetic solution now becomes more bioavailable so that the body doesn't have to work as hard to accept that anesthetic molecule. When we have an acidic solution going into a more neutral environment, the body has to break that down a lot more to bring it into the nerve cell, okay, without getting too
Yeah.
scientific-y with everything. So when we apply that buffering agent, now the body doesn't have to buffer the anesthetic in of itself. It's already there. So more of that anesthetic molecule can go to the nerve, which then therefore means we get faster onset of anesthesia. And then potentially we can give less anesthetic because we've achieved anesthesia sooner. So we're not going, oh, I need to give more anesthetic to my patient to get that profound anesthesia.
It makes a huge difference. Like
Yeah.
when you have patients that start saying that they can tell, like, you know, that it's making a big difference and it almost
Yeah.
makes it painless for them.
It really does.
Yeah.
And there's a little bit with that sodium bicarbonate in there. When, you know how like sometimes when you go to insert the needle, there's like that little drip of anesthetic right at the very tip
Yes.
of the bevel. Like when that touches the tissue, it actually can also act as a little bit of pre-anesthesia as well.
Oh, yeah, that's awesome. Yeah, I hope that more and more people will start using it. And it's nice because at my office, we did it ourselves with like a compounding
Yeah.
pharmacy, but it's nice that we can just have it pre-done with the products that you mentioned. That's pretty cool. Before we close out here, I did want to touch on medical histories because you told me something previously. God, I hope you remember because I don't, but it was a medical condition that I didn't know about that we need to pay attention to.
Yeah. So, well, there's a couple of things on patient's health history. I know which one you're talking about, so I'll
Good.
say that one last.
Okay.
But with the rise of cannabis use, we're going to see patients with elevated blood pressure. So we need to be aware of that. Also, the patients that are using cannabis are going to be a lot harder to anesthetize because of the way that their opioid receptors are. So buffering your anesthetic for those
Mm,
patients will be very, very nice. And be prepared that your patients are going to burn through that a lot faster
okay.
as well. The other thing, just our paying attention to medications, our patient's cardiac status, our patient's diabetes status, those can all create an impact for our patient's success with their anesthesia and our dosaging for that. But one of the medical conditions that I think you're talking about is like a connective tissue disorder.
Yes.
There's a general overarching name for it. It's Ehlers-Danlos syndrome. And these individuals have a hard time with a lot of different things. You might see that somebody with Ehlers-Danlos syndrome will have a higher incidence of a positive aspiration and also therefore a higher incidence of a hematoma developing. I've seen that with someone that has had a PSA injection and then their whole entire cheek just swelled up and turned purple. And that was how they were actually diagnosed with
Oh,
Ehlers-Danlos. They didn't even know that they had that. It was like, what happened to this person? It was actually in a very benign environment where there was no positive aspiration, there was nothing involved with it, but then that
hmm.
happened. I know of individuals that when they have that condition, like even general anesthesia, they will wake up or have a hard time maintaining that anesthesia because of the way that their connective tissue is. And there's so many different variants of that particular syndrome that to be able to go into grand detail with all of that, I just don't have that right now.
Yeah.
But basically, you just think the outer portion of the nerve has connective tissue on it. And if you've got a connective tissue disorder, that's going to impact the nerve.
That's crazy. Yeah, I remember when you first told me that, I was like, what? Like, I mean, I've been doing this a while and I feel like I'm relatively informed, but I had no idea. So, if people want to learn more about you or take any of your courses or whatever, what's the best place for them to get in touch with you?
Well, of course, there's the social media, Instagram, Facebook, Teacher Tina RDH. On LinkedIn, I think I'm just Tina Clarke. I'm not as busy on LinkedIn. I should probably do that more. My website is Teacher Tina RDH. And I have on my website, I have links to some on-demand courses. I have links to books. I have two books out. One is a laminated chairside guide that just goes over injection techniques in of itself. And the other one is basically takes the textbook, the anesthesia textbook, and puts it into real world conversation. And that's available as a PDF download right now. And I'm in the process of, I was hoping would have had this done at the beginning of the year, but in the process of getting it formatted for print version as well.
God, I seriously don't know how you do everything you do. Oh, wait, hang on. Let me grab this thing. Just one second. So
Yes, you've got it
I
right
got
there.
this. Yeah. So, and this is so key too, because like we have a lot to remember when we're chairside with patients and we are not going to remember everything. So this little chairside guide is like, it's so helpful. I mean, it's got all of these like awesome graphics and pictures and stuff. So they can get this on your website.
Yeah,
Okay.
there's a link for that on my website, and it's laminated, so you can have it right there, chair size, so you can wipe it down and not have to worry about any kind of cross contamination or anything like that, which is always great, and it makes it as a nice resource for the entire office because there's times where people are like, what are we doing? And even for the team members in there that are supporting the clinicians who administer anesthesia, it helps them know like, oh, we're getting ready to do a procedure in this area. What injection am I going to be doing? Like, what injection do I need to prepare for, right? Because oftentimes it's that supporting clinician that might be preparing the patient.
Awesome. Well, thank you so much for your time today, Tina. I know everyone learned a lot from you as always. And thank you everyone for listening. We will see you next time.
Thanks, Steph. Bye.
Bye.